In the late 1990s, pharmaceutical companies producing opioid pain relievers attempted to abate concern about the addictive quality of their products and reassure the medical community that patients would not become addicted to prescribed opioids. As a result, healthcare providers began to prescribe them at high rates in order to treat their patients' pain, ultimately leading to widespread prescription opioid misuse. This misuse subsequently made it clear that these medications could indeed be highly addictive. Eventually, opioid overdose rates skyrocketed. In 2016, 11.5 million Americans misused prescription opioids, and 2.1 million developed an opioid misuse disorder. This drug issue has become a public health crisis and has been deemed an epidemic. Public health surveillance of the opioid epidemic helps to answer the where, when, who, and how questions regarding the crisis. Currently, it is believed that opioid overdose deaths are most prevalent amongst middle-aged, non-Hispanic white males in the Midwest and Northeast. This following study will further delve into who is affected by this epidemic through understanding social networks. Social relationships determine the degree to which individuals are interconnected and embedded in communities, and as a result, they can influence health and longevity. Social networks both are embedded in a larger macro-social context, which is based on things like culture, socioeconomic status, and politics, and inform micro-psychosocial mechanisms, which can involve social support, social influence, and social engagement. And further, these micro-psychosocial mechanisms can in turn affect behavioral, psychological, and physiological health. Marriage can be understood as a type of social network. As a result, marriage can affect a person's micro-psychosocial mechanisms and influence patterns of risk-related or health-promoting behavior. Studies have shown that peers, including romantic ones, are seminal in the lives of adolescents when initiation of risky health behaviors like substance use begin, and again in adulthood when changes related to cessation or protraction of risky health behavior or health promotion present themselves. The rate of marriage in the U.S. has been on a steady decline since 1990, and in 2017 the rate stood at a mere 6.9 per 1,000 of the population. Depending on how marital status interacts with substance use, should this decline be alarming? Specifically in regards to substance use and its relationship with marital status, there are three current theories about the interaction between the two variables. The first theory is the marriage effect, which explains that married people tend to be less likely to use substances than never married or divorced people. In a sense, there seems to be a protective quality about marriage that safeguards spouses from engaging in substance use. The second theory is spousal similarity, which explains that spouses tend to have similar substance use habits than would be expected by chance. Both assortative mating and convergence processes seem to contribute to this similarity. Assortative mating refers to the two potential premarital causes of spousal similarity: social homogamy, which is when people pair with others on traits that are correlated with substance use, but not necessarily substance use itself, and phenotypic selection, which is when people pair with others on the substance use trait. Convergence refers to the potential postmarital cause of spousal similarity, when spouses grow increasingly similar over time. The last theory is that marital quality affects substance use, as more negative marital quality appears to be associated with more substance use. Despite this conjecture, some believe the reverse in that substance use actually affects marital quality, given that research has shown substance use playing a role in marital interactions, marital satisfaction and stability, and male-to-female intimate partner violence. Studying the relationship between marital status and prescription pain reliever misuse is important because this kind of research can have implications for developing more targeted and effective prevention and treatment programs. In this cross-sectional study, I set out to observe if and how marital status and prescription pain reliever misuse relate to one another. Secondary data from the 2016 National Survey on Drug Use and Health, NSDUH, were used to help develop an index of prescription pain reliever misuse using initial, recency of, and frequency of misuse variables. Marital status was used as a proxy for level of engagement in a committed romantic relationship. The determined covariates included in the analysis were age, sex, race, and ethnicity, education level, annual income, and number of children in the household. For initial misuse, 25,195 respondents were included in the analytical sample. In the simple logistic regression model, both being divorced or separated and having never been married were strong indicators for ever misusing prescription pain relievers. After controlling for the relevant covariates in the multiple logistic regression model, both being divorced or separated and having never been married were still strong significant indicators of ever misusing prescription pain relievers. In the simple logistic regression model for recency of misuse, with a sample size of 2,089 respondents, being divorced or separated was a strong indicator for misusing prescription pain relievers within the past 30 days. However, the significance was lost after controlling for the relevant covariates. In the simple logistic regression model for frequency of misuse, with a sample size of 2,033 respondents, neither being divorced or separated nor having never been married were significant indicators for misusing prescription pain relievers more often than prescribed. According to this study, divorced or separated persons are 38% more likely to ever misuse than married persons, and never married persons are 60% more likely to ever misuse than married persons. Ultimately, this study indicates that there is some association between marital status and prescription pain reliever misuse, but the way in which and in what capacity these two variables interact remains unclear. The limitations of this study were that the variables chosen to probe prescription pain reliever misuse do not fully encompass prescription pain reliever misuse, as only 3 questions of the 2016 NSDUH were considered. Data from other prescription pain reliever misuse variables in the survey should be aggregated to more accurately and precisely convey the association between the two variables of interest. Furthermore, this study only looks at misuse, which is not necessarily as concerning or representative of the opioid crisis as dependency or abuse. Additionally, this report only looks at marital status rather than relationship or cohabitation status. It is important to acknowledge that there are people who are in committed romantic relationships but are not married, but the same phenomenon witnessed in this study in regards to marital status and prescription pain reliever misuse could also be present in those relationships. Future research should consider compounded drug use, age at marriage, length of marriage, same-sex couples, employment status, and geographic location. These other variables could help elucidate how marital status and prescription pain reliever misuse are interacting. Additionally, future research should employ qualitative approaches to investigate which theories, marriage effect, spousal similarity, or marital quality, could be held accountable for the observed association.